Yeah, hi. This is the continuation of our micro review. Uh, Let me get it all set up. I was just doing a different one. So we're coming there. Yeah, influenza vaccines was the last topic. Again, other things that I know we're probably in the same time, just to make sure I may have mentioned it in passing. I think I did with regard to respiratory syncytial virus. Now it's like I call it the big three. Uh, Influenza, COVID, and RSV, we look at them now, they're tested for commonly. I mean, it's almost in the absence of testing positive for influenza and COVID, you end up with RSV. But the big thing with RSV, other than the infantile respiratory distress syndrome, which is most notably associated with, is definitely the croup in younger children. And I told you enough anecdotes about that. And we even see a little bit in adults, but really it's much more common in young, toddlers and not well, I'd say preteens, that type, but probably more so toddlers and maybe pre-K K level kids that are there. I mean, it's relatively self-limiting. Fortunately, it just has to, and I think the cool mist humidifiers have helped a lot. One thing, just to emphasize, a couple of questions on is tuberculosis. Big problem is the capsule. It's a mycobacterium. It grows very slowly. We have to use the acid fast test to get a rapid definition. That's it. So fast doesn't mean rapid, but it is rapid. Because in 10, 12 minutes, I know some of the students were doing this for unknowns, that the acid fast, it's 10, 12 minutes. And if you get a positive, now you have your diagnosis and you can begin to treat. And it's, as always, imperative to treat things quickly. But the big thing is, it's again, the frame acts like it's a bacterial disease, acts like lung cancer. Gets into your lungs, it forms those tubercles, they necrose inside, they cause a lot of damage, and you lose lung tissue. But it's because the surrounding blood vessels, when the tubercles open up and the blood vessels pick up, and the tuberculosis goes all through and affects goes to potentially all the other organs that are there. There's really no place that's limited by this. What will happen is now you get this disseminated one, and you know coughing up blood, and it's blood that's kind of swirled with mucus. It doesn't really change the mucus per se, but little bits of blood swirling, and is very identifiable with it. That's a big problem. Cancer does similarly. Uh, Night sweats, cancer does similarly. Weight loss, cancer spreading when it metastasizes, all of those things. So, so the distinguishing feature is to get the sputum sample and be able to identify that. The problem is it's airborne, which means it's, and again, I've emphasized that a lot. Sitting with patients with that, you have to take a lot of precautions. If they're actively with active disease and you're having to treat them, that's a difficult management problem. They have to be in reverse isolation. You'll get all that if you're going into nursing and all the criteria for that, which start to bring us now, and that's pretty much the end of respiratory and skin. Now we're into really the second half, which is pretty much repro. And then lastly, wounds. And wounds will certainly be covered next week, I suspect. And I'm doing this on Thursday, 4/23, that on 4/24, I'll try to get through the rest of the sexually transmitted diseases. Whether I have enough time to do all of HIV or not, I do not know, but maybe we will. And then I'll dedicate the last three lectures to wounds, and we'll be good to go. And so we talked about most common infection that we see, probably associated with nosocomial infections by far, urinary tract infections, and particularly bacterial bladder infections in catheterized patients, much more so ladies and men, but it happens in both. And the principal agent, we talked about the anatomy, is E. coli, the vast majority of the times. There's others, okay? But the real big player is E. coli with regard to that. And again, it's got that particular strain of E. coli. It really adheres, those pili adhere to a lot of structures. That's the one I'm not going to go into the name or the acronym aside for that. It treats pretty easily. I mean, if it's something that came from a home-related problem that wasn't involving catheterization, you're probably going to use one of those combination sulfates like Bactrim or Septra. But If it's in the hospital, we were probably on Cipro or whatever the generic brand of ciprofloxacin they're using, or whatever the most popular version is today, which I don't know. And so, and typically when you see vaginal drainage, the presumption is vaginal yeast infections, and you're thinking about Candida albicans. It's as simple as that. It's probably you'd start with that. You assume it's this yeast infection. You principally would treat it with diflucam. You can use topical agents. You can use other agents that are there. I mean, but that's really number one. I'm not going to ask you about this new Candida auris, I would pronounce it. This one but I would be curious to just see when you get into that. If somebody ever wants to get back to me what they've heard about it, I'd be very interested to hear about it. I'll be looking more of it. And then we look at gonorrhea, and I spend a lot of times with gonorrhea, very, very severe gram-negative diplococci. We haven't talked mostly. You haven't seen that a lot. When you see gram-negative diplococci, particularly if they're living in white blood cells, that's pretty much diagnostic when you're dealing with any type of urinary tract drainage, whether from a swab from a female or drainage that's been expressed from the penis in the male. Bang, that's what it is. It's terrible complications. Very painful, male, maybe less so in the female, I would agree. Even potentially asymptomatic until it hits PID, then it's a big problem. And it's a discharge disorder. Pure and simple, you're going to see a discharge. Chlamydia, most common bacterial STD, period, end of sentence. Same thing with discharge, burning, frequency, transmitted. Theoretically, you can transmit any of these non-sexually, but typically it's not because they don't survive well. But I mean, theoretically, it could. And if somebody will get into the definition of what sexual is, and I'm not going there. Ectopic pregnancies, the Z-Pak or azithromycin is typically what's utilized for it. Spent a lot of time on syphilis. Treponema pallidum, it's not culturable. Again, a lot of people got that wrong vis-a-vis Koch's postulates. Please remember it this time that are there. And it's always treatable, really. Okay? The only time it's really not treatable is when finally tertiary syphilis appears. It's very contagious. Okay? But the contagious limits, once it gets into latency, you probably are away from being contagious, though it's still treatable. Okay. It can cause a lot of problems outside with regard to tertiary syphilis, the problems with the newborn. It's crazy. It's crazy. And I mean, it's just sort of an interesting conundrum with regard to that. So really, it's really what happens when you see that chancre. And I'm sort of going along trying to get you the right answer when I'm looking at the questions. The chancre is, really a tremendous warning sign. It's teeming with spirochetes. It continues to do that. They get into the bloodstream. It's highly contagious. It's in all of the secretions, all of the secretions. Kissing, we talked about that, in saliva when it gets to be secondary syphilis. And even when that goes away, now typically when that goes away, okay, the nature of contagiousness disappears. It's in the bloodstream more so than any place else. And so probably when it ends latency, I mean, really, maybe early on in latency, it's still contagious. As you get later in latency, maybe it's not. And so there's a lot of problems, but effectively, you can treat this disease, okay, all the way up in time until tertiary syphilis effectively appears. I think that's basically the best way to say it. It's still relatively contagious pretty much until tertiary syphilis. It's asymptomatic. It's horrible until those gummas and those other things or mental changes or other changes occur. And it certainly causes significant problems. And you can continue to treat it. That's really very, very interesting. So again, you have that's just like the spirochetes. It's immunological in nature. The initial damage is that skin chancre, but after that, it's all immunological. What occurs inside it, and there's so many areas. I told you we call it the Great Masquerader, just like mononucleosis. It could cause any symptom that's possible there. I mean, so in the old days, you were in the back of your mind, you started heard these. I'm feeling lousy, my glands are swollen, but I haven't had a cold, and it's all of a sudden, oh boy, what's going on? We didn't do the HIV unit, but the principal thing you should have gotten this in immunology. It affects the CD4 cell. That's what's going to become the helper T cell, the single most important immunological cell in your body because it helps all the others. Okay. So I really think you need to be aware of that. We're going to deal more with HIV. Effectively, what happens and the transition from HIV to AIDS is very straightforward. That when it hits that CD4 cell line, they grow in those helper T cells. And when they're released, they infect other helper T cells. So your helper T cell problem, your helper T cell, I beg your pardon, population effectively begins to diminish. And it takes X amount of time, typically 2 to 10 years, for that to reach a level below when your immune system will no longer function. And I forget what the numbers are. And I mean, whatever, maybe 200 per microliter. I mean, I really don't know, and certainly would not ask you. And it's certainly published, but we know it manifests itself without having to do the constant blood test by what we call AIDS defining diagnosis. So if someone's HIV positive and they get tuberculosis, or they got that PCP pneumonia, or they get a deep respiratory fungal infection, blah, 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 blah. There's Kaposi sarcoma. All of those things, bang, now you have AIDS. And what that means is it either has not been treated, or it was not treated appropriately, or it hasn't been treated continuously, whatever. The treatment has been unsuccessful because people either didn't do it, or for whatever reason, it's one of these fulminating cases and there's probably someone who's fairly sick otherwise with other problems. Long story short, what does fatal mean? You're going to die sooner than your expected lifespan. And generally what happens, it's very unpleasant because it goes on to damage all the organs, and inevitably minor infections become major infections, and it's not pleasant. I mean, if you see the pictures, just go on Google and look up Freddie Mercury, and look at Freddie Mercury at his concert in 1986 at Wembley Stadium, and then look at him about 3 years later when he did the final time we saw him doing a music video. Okay, and it's dramatic, almost unrecognizable. And he succumbed slightly after that in 1991 to AIDS. Okay, hepatitis, big problem. The one we see the most of now is hepatitis C. Hepatitis A is not, again, it's fecal to oral. It's not considered an STD. Hepatitis B, there's a lot of people, most people are immunized. They're there. Again, maybe I don't know if there's that controversial, but it's one of those potentially optional immunizations. And then hepatitis C, that's the biggie. That's in the old days, it was called serum hepatitis, was hepatitis B, infectious hepatitis was hepatitis A. So be aware of that, please. We haven't gotten to it yet. This is coming up. That's Trichomonas vaginalis. I mentioned it as the last of those discharge disorders on Monday. I beg your pardon, yesterday, which was the 22nd. The drug of choice, because it's an anaerobe, is metronidazole. You're going to see a lot of metronidazole. Remember, metronidazole is the drug of choice for that bacterial vaginosis, the one that has that unpleasant, stigmatizing odor, the way I described it. And again, I reinforced the point. Review your Lyme disease. I think there's 3 or 4 questions. I think you'll be okay. That's there. I talked about herpes simplex and the life-threatening kind of encephalitis. I talked all about the problems with pelvic inflammatory disease, whether it was tubal pregnancies or ectopic pregnancies, a better way to describe it, ovarian damage, infertility, early onset hysterectomies, the length of time we've already talked about for the duration of antibiosis. Again, what's bacterial, what's viral. The big viral ones we're going to see, other than HIV, herpes simplex. Okay, basically genital herpes, which is herpes simplex type 2, HPV, certainly, which we've gotten to a number of times. We're going to get to it again. All of those are certainly important. Where the bacterial ones, chlamydia, gonorrhea, syphilis, Lyme disease, they're all in that. So know which is which, the distinction between antigenic shift and drift, that's important. Okay. The complications of gonorrhea, I talked about its effect with septic arthritis. And the last unit, and there's maybe, from what I can see, there's maybe like a 10 question arc on wounds. That's why I do that by intent, because I know it comes at the end. Sometimes it's freshest. But we're going to talk about it in length, in general. The big ones that we have to deal with are staphylococcal organisms. Used to be free, and again, Staph aureus, public enemy number one, as far as I'm concerned. But we're going to have to be on top of that. And now we see in the hospital certainly a lot of Staphylococcus epidermidis, because that's basically something that attacks compromised hosts. We call it an opportunistic pathogen, an opportunistic infection. This is really not a pathogen, but it's staph. And I mean, it can be just as nasty. We'll talk a little bit about MRSA, and we're going to talk a little bit about MRSA, methicillin-resistant Staphylococcus epidermidis. We're going to deal a lot talking about tetanus and non-tetanus prone wounds. That's an important point on the test. We'll talk about gangrene, what it is, what it isn't. What's the difference between gas gangrene, dry gangrene, and wet gangrene? That's going to be important. The role of Pseudomonas aeruginosa and burns, and why that's so important. It's interesting. I'm going to tell you, there's a recent article I saw yesterday on necrotizing fasciitis. It's caused by, because we talked about it before, group A beta hemolytic streptococcus, the vast majority of cases. There is a new one whose name is not going to be on there because it's relatively recent. There's a strain of Vibrio that they identified in water. I do not know where, but I will look it up. When we talk about that during wounds, where people were commonly swimming or surfing. I think that was. So I don't know where that was, but I'll look it up. There are some other, for lack of a better term, exotic bacteria, because Streptococcus pyogenes is hardly exotic, that have the same ability to. I don't know if it's the same mechanism. I suspect it is. We have to talk about bite wounds, and the two big players you're going to learn about are called your old friend Staphylococcus aureus. Interestingly, not MRSA. It's not going to be a methicillin-resistant strain. And something called Pasteurella multicoda. That's common in all sorts of animals that we might encounter, particularly dogs and cats, which are the most common ones, as you might guess, because they're in our orbit a lot of the time. And so we're going to talk about the drugs of choice for that. We're going to discuss human bites and some of the problems, and human bites are worse. And I think that will cover it. All right, I think we're done with this. Add this to the other ones. I hope this all helps. See everybody tomorrow, Friday, on the 24th. If you're there, hopefully you are. It's getting a little sparse on Fridays.